Assalamu alaikum wa rahmatullahi wa barakatuh. Alhamdulillah, rabbil alameen, wa al-aqibatu lil muttaqeen. As-salatu was-salamu ala ashrafil mursaleen. Sayyidina Muhammad wa alihi wa ashabi ajma'een. Today we have a very special show. It's called Kick Your Habit, and it is something that will really interest all of you. We're not live today, it's a recorded show, and we'll discuss that with you in a short while. We have been taught in all our scriptures, in the Quran and in the Hadith, about various addictions and how forbidden they are. And today we're seeing a whole splurge of addictions, and there's a big challenge that we face. And in keeping with our principles of morality, we know that one of the challenges is to fight wrong and to do good, and to also resist wrong. And it is such a big task for parents and people that are involved in some form with addictions of various types. And we will be discussing a program, it's a World International Day called Kick Your Habit, where we have today two special guests, Adrie Vermeulen from SANCA, from the National Division, and Adèl Grobbelaar from the Wedge Treatment Center in Linders. Welcome.
Thank you.
We're really happy to have them. Now, SANCA is the South African National Council Against Alcohol and Drug Abuse, and perhaps we'll just start with a very brief introduction from Adrie, just to tell us what is SANCA.
Thank you so much. So SANCA is a national body, and we've been in existence since 1954.
Okay.
So we've been there for many, many years. And through the country, we've got treatment centers and affiliates. We've got 30 treatment centers. And those affiliates of ours, they have then service points. So we've got over 190 service points for people to access treatment from.
Now, I remember when we were at medical school many, many years ago, one of the outreach programs we had to go for on a certain day was to go to SANCA. But that time, I'm talking about in the 80s, there was a huge focus on alcohol, and that's why SANCA, ending with the A, and there wasn't much on drug dependence.
Yes.
And things have really changed over time. So you've obviously incorporated, and drug has become a big thing, and it's not just alcohol.
Yes, so we've realized that alcohol is just one part of the problem. If you look at our statistics, you will find that we've got cannabis and alcohol being the two main substances abused by people. And then from there, we would get the other kind of illegal substances, but we also have an increase of the use of legal substances like your over-the-counter and prescription medications.
So the spectrum and scope is very, very wide.
Definitely very wide, and we've also included some of your process addictions now to say that people don't only get addicted to chemicals, they also get addicted to behaviors. So we also look at gambling, you get sex addictions, you get food addictions, you get shopping addictions. So there's a spectrum of different addictions.
So often your addiction, on process addiction, a person would relapse on process addiction before they relapse on the drug. They use the drug to feel better because of the process addiction.
Okay, so there's a lot of terminology, and we'll explain that as we go along. Today is Kick Your Habit Day, right? And that is one of the big things that you guys are going to be concentrating on from today for the next 7 days. You want to just explain what that is?
So on the 26th of June, it's International Drug Awareness Day, and every year across the world, the countries that has said that they will participate in reducing illicit drug trade and drug trafficking and the use of illegal substances. Those countries then would do campaigns and awarenesses throughout the year, throughout that day, and you will find that South Africa, we're celebrating that as well on the 26th of June because we signed that treaty to say that our country will also stand against this. And from there, we've developed the Kick Your Habit campaign that runs this whole week from the 24th to the 27th till the 28th of June, where we're running this whole campaign to create awareness around how difficult it is for people to really stop something like this, and that we want people to really understand what it feels like to give up something that you love, that you enjoy, that you really like. And that for me is the focus of this. that we
Addiction
really want
has got
to do
two
that.
legs. It's got a physical leg and a psychological leg. And if somebody gives up, for instance, if they love coffee and they drink an excessive amount of coffee, then if you give up your coffee, you're going to go through withdrawal a certain time of the day, and kicking the habit underlines both the physical and the psychological side.
Yes.
So what are you promoting now? You asking people to hold back on something that they're addicted to for a period of 4 or 5 days, 7 days.
Yes.
And if they can achieve that for 7 days, then they can probably achieve it forever.
Precisely, yes. So the first 3 days is the most toughest to break any kind of habit.
Okay.
So that's when we really see that you're going to go through with the withdrawals on day 3.
Okay.
And it's really going to then be tough after day 3. So if people can get through the first 3 days without using, say for instance, coffee, or without social media, or it's any kind of behavior that you would like to give up, then I think it becomes easier after the first 3 days to overcome
We also
that.
hope that if they give up, that they would feel the benefit after 7 days.
Okay.
You know,
Yes.
if you drink a lot of coffee, maybe you don't sleep so well, so all of a sudden you sleep a little bit better, and they would continue kicking the habit.
Okay, so we have just come off our month of Ramadan, and it just somehow coincides now with the timing,
Precisely,
where
yes.
people were giving up certain habits, giving up food for the day, and other things that we were promoting in terms of our purpose of fasting is not just to stay away from the physical element, but also stay away from anger, try and develop some good habits. And we again promote the whole idea that if you can do that for the 30 days, you'll be able to do it for so the principle is the same. It's a behavior modification and how you deal with that. So your campaign, what does it entail? Obviously you're on media today. What other tools are you using to create this awareness? And it's a national campaign.
It's a national campaign, so we have press releases that is sent out through through the whole country to the different agencies, and then we also are supported by radio stations during this whole week, and we also find that we also have a Kick Your Habit page on our Facebook that people can join, and it will give you tips on how to do this, how to give up this habit. And it really helps people to understand that to have something like this is life-changing if you can manage the 7 days. And you really get some insight into what it feels like for a person who's got to give up a chemical in a treatment center. And we're trying to break that whole stigma of people seeing addiction as something that happens to somebody else, number one. It never happens to me.
Of course,
It never happens to my children or my family until it does happen to you. And secondly is to really understand that this is a brain disease. This is not something that is just because the person has a weak will or they're not strong enough. Really, when you become addicted to something, that really takes away all control, and it affects the brain functioning of this person.
So one of the messages from the program today is you're encouraging people to go to your Facebook page and look at the tips that are there, and how you're going to be able to manage, or rather measure the outcome of your campaign. Are there any ways that you can, at the end of next week or at the end of the month, say, our campaign had some kind of success rate?
Yes.
Is it possible to check that?
Yes, we've added a poll to the Facebook so people can indicate which one of the behavior addictions they want to give up for the week. And then afterwards there's going to be where you have to assess yourself, and give us feedback on how did you do in this week, and that will give us some answers as to how successful people have been. But even if people are just willing to try, maybe they fall out after day 3 to check their Facebook page. Or their social media. So it might happen that they might fall out, but at least they've started trying and they've realized that it's very easy to relapse.
Yes.
So even if you make a decision to change your life, you make that decision out of goodwill. You want to really do it, but you realize that you just can't do it. And that's exactly what happens to our clients when they go in for treatment. They really want to recover, they really want treatment, and then they can't get there. So relapse is also part of the process. Never give up then, you know. You must try again. And that is the message we also want to give people. So even if you don't make the 7 days, the success is not about the 7 days if you complete that. It's about, are you understanding the process? You then have a better chance to understand yourself, and through that learn how to stay clean.
So it's, in a way, making people aware that they have the problem, recognizing that it's difficult to treat it and to deal with it, but the fact that there is help out there, and then they'll be able to say, okay, I can manage on my own if I could succeed with this particular program for now and be part of a national thing, and if they can't, then they come to you and come to your kind of treatment center.
Definitely.
That's very, very interesting. So we will continue with the discussion after the ad break. Assalamu alaikum. Assalamu alaikum. We're back on our Tuesday slot, but today we're not going live. It's Health Matters from the Islamic Medical Association. We're discussing a very special program. We're talking about drug addictions and chemical dependence. We have two guests from SANCA, Adrie and Adèl. We really thank you for coming today. You guys got a national campaign going on. Good introduction in the beginning, talking about your Kick Your Habit campaign. It's such a huge problem, this in terms of, we know internationally, and you have changed your focus in that you know that the supply of drugs is something that you cannot influence. And it's really a huge problem both locally and internationally. So your focus is on the other end, is in terms of prevention and treatment. So one of the tools that you're utilizing for prevention is what you started here, is an awareness program for this week, asking people to see if they can just stay away from something for a few days and hopefully continue. What other measures are you using in terms of preventative measures?
So the preventative measures is what we call demand reduction. So we want to make sure that there is no customers for the dealers out there. You know?
That's wishful thinking, but hopefully you'll get there.
So what we try and do with our prevention programs, we focus from as young as possible. So we've got programs running in ECD centers and in primary schools and in creches for 3 to 10-year-olds. We call it Boogie Woogie. And it's a puppets program that teaches kids resilience skills and refusal skills when they are exposed to chemicals, what to do. And we teach them that they are special, that they are unique, and that they don't need any chemical, you know. So that is the focus of that program.
So you're starting very early, and one of the reasons for that is your statistics have shown in South Africa that the problem of dependence and drug use is going to an age that is earlier and earlier. And internationally, I think we're one of the worst countries. Is that correct?
Absolutely. So they've looked at the onset age, and we in South Africa have dropped tremendously. So we between 11 to 12-year-olds, that is when our kids are shown to have started experimenting with a chemical. And we know that in some cases even younger, depending on the family circumstances and the history.
It can drop to 9.
It can drop to 9, and we've had even 7-year-olds in our treatment facilities. So you find that it's dropping tremendously. But the average age is around 11 to 12-year-old. So for us, we need to catch them before they get to high school. Because if they get to high school, they're already exposed, they already start experimenting, and then it's very difficult then to change that belief system.
And why would you say that they're starting at such a young age? Is there ease of availability?
Absolutely, it's the accessibility. We've got.
I think you need to look at your community factors as well.
Yes. Right.
We our divorce rates, you know, South Africa is first where they should be lost in certain things. Our divorce rate's very high, so you get a lot of single parents who can't afford daycare and things like that, or aftercare. And the kids sort of make friends with whom they feel comfortable with. And unfortunately, it's homes with other single parents as well. And there's a lot of bullying in schools and peer pressure. And unfortunately, with divorce, you know, you've got your kids with a psychological disadvantage sometimes. So they fall prey to drug dealers.
And then poverty plays a role?
Poverty plays a major role, especially in our townships, where you get a lot of child-headed families. And your drug dealers offer these kids a way to make money, so they start dealing to either support their own habit or the family at home, the siblings.
And a good proportion of kids are not going to school.
Precisely, yeah.
So they're sitting idle, you're finding that, and then basically they don't know what to do, and they become vulnerable to the dealers.
They do, and even kids going to school that start experimenting drops out of school. Our dropout rate is quite high as well.
That's what I was referring to, yes.
Yeah, so they never complete their schooling, and with our unemployment rate, what chance do they have to get a job? So, and our country lacks skills development programs where they can go into, and unfortunately, a lot of these kids is clogging the police's work as well as the Department of Justice, because they get arrested for either dealing, possession. They have to go through a whole investigation, and then, you know, what do you do with them? You can't throw them in prison.
No,
there is diversion programs, but it's not effective enough to stop it.
So it's a big task that you have, and you've got a national footprint, but do you think you're covering most of the areas, or you're just scratching the surface?
No, we're just scratching the surface. I would agree with you there. It is such a pandemic, actually. If you look at the number of people using, if you just look at the statistics shows that there's about 2 million active users right now in our country that needs help.
Is that in the children's age group, or
across the board? From the CDA, that's our Central Drug Authority, they've done some work, and they've said that we've got 2 million people in need of desperate help. So that is across the board. But what is very concerning is when we look at the statistics, we see it's our young generation that is mostly affected. So your age group between 18 up to about 30, that age group, and even 35, if you look at the numbers in treatment centers, they are the ones who are accessing treatment. But they started way before that time, before they got to the treatment center. This has developed over years before this problem has really reached a point where they would need treatment for it. So we really are seeing that it's affecting our young people the most, and it makes sense. If you look at the developmental age of an adolescent, where they are right now, they want to experiment, you know, with different things. They want to, the friends is the most important part. The family is on the back burner, and the friends become the most important part in their life. And it's all part of what they have to go through to develop into an adult, you know. And unfortunately, drugs fits in with that developmental stage where the young children are at.
The other concern is the kind of drugs on the streets nowadays. Some of them, if you've used it once, it causes psychiatric disorders. You know, if you look at tuck and flakka and things like that, they use it once, they become psychotic, and nobody can know when they come down. You know, so that's an expensive price to pay, to give up your life. So research has also shown that if they start using cannabis in early teenage years, the possibility is greater of them developing schizophrenia in their 20s. So it's got far-reaching consequences.
So the drugs cost money. And we spoke about the poorer communities. We'll come back to the affluent. So the poorer kids, where are they sourcing the drugs from? Because they need to buy them.
There's one word: crime.
And I was hoping you're going to say that, because there's the big link between that. So the consequences for the community and for the society are huge. And you need participation from everyone. So it's not just the Kick Your Habit campaign for the actual addict, but for everybody to be involved so that you can reduce. So how are you targeting people, the support group, the community, societies? You have special awareness programs?
Yes, we do. We are part of CATCA, which is an American-based organization. And what we've started doing is to establish community coalitions within communities. And that means that every community member has a role to play, you know. So it's not, like you were explaining now, it's not only the family's problem. It is the whole community's problem. So the whole community needs to stand together to try and address this. And it starts with community safety, you know. So do we have proper roads, and do we have proper lights in our streets? And it starts with the small things like that that needs to change. And in the parks where we know that dealers are frequently selling drugs, what are we doing about those hot spots? You know, what are we as a community addressing? So the community coalitions is very important for us, and we feel that's actually the answer. Also to create support systems within our communities, because communities are killing our Nayope people. You know, there's so many reports of them taking matters into their own hands. And yes, and so we really want to change the concept of community around this person is ill. They need help. They need medical help, and they need psychiatric and sometimes psychology, from the psychology side as well. They need help. They are ill. People don't see it that way. They just see this person as a person that is a delinquent, that's a misfit in society. They don't see this as an illness at all. This is where it differs from other illnesses like diabetes or hypertension. We have more sympathy for those kind of illnesses than what we have for a person with an addiction problem.
Yeah, I think it's also partly because drugs has been linked to crime.
Yes,
and there's been this whole
it's
culture.
a
I mean, so many
stigma.
movies, you know, that the drug guys are the bad guys and the good guys are the police, which obviously you have other challenges here with the police in terms.
Yes.
Do you guys work with them?
Very closely with these coalitions. We work closely with the CPFs as well. We work closely with the local drug action committees, and we work with JMPD, we work with the police services. All the role players should be involved in these campaigns, because it's going to take all of us to make a difference.
Yeah.
To me, it even goes further that you know, it starts with giving parents the control back, because some parents, you know, lose control, and I think, you know, the values in the home plays a big role, and we need to revisit that as well.
Well, you
so
got
who's the parent, who's the kid?
Yeah, and you actually alluded to it before, is you got the child-headed families, and also you got the single-parent families, which are very common in certain scenarios in our country. And you got especially a female-headed family. The poor lady has to go to work, she's got children, and now she doesn't get support from the father of the children, so she's got so much on her plate, and then now she still has to worry about a value system that she has to bring back home, and she doesn't have much support. We have lots of grandparents that are involved, and so now there's a big gulf in the thinking, because now you've got young children who look at life very differently, and a grandparent who's grown maybe 40, 50 years ago. They don't know how to deal with these issues, so you've got lots of problems. Hopefully we'll address some of that after our next ad break. Assalamu alaikum. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to Health Matters. We're discussing drugs and drug addiction, special week for SANCA in terms of their awareness campaign. They have a program called Kick Your Habit. There's a Facebook page. We urge you to look at it, both for those who have problems with drug addiction, alcohol addiction, chemical dependency, and those in the community that want to support either family members or friends, or just out of your own interest in trying to attack this huge social problem. But it's not just a social problem, right? There's a huge medical link. the dependency, the chemical dependency in terms of the brain. You want to just touch on that a little bit, then we can discuss a bit of the treatment?
Yes, so if we look at the definition of what is addiction, and we look at the National Institute on Drug and Alcohol Research in America, they'd say that this is a brain disease that affects the functioning of the brain. So, and there's 3 parts of the brain that it mainly then affects. So I always use the example of my fist, you know, to say that there's the 3 parts of our brain. It affects the brain stem that controls the rest of the body. It affects the limbic system, which is my fingers here, that's in the middle, and the most important part, the frontal cortex, where our logical and rational decision-making part of our body lies, our brain lies. So when we look at a chemical addiction, and as we use drugs more and more, this ability for the frontal cortex to control my impulses, you know, from my limbic system, my reward system, is overridden. So my brain is completely then affected by reward. That's what it seeks the whole time, and that is what it wants the whole time. And it overshadows my good decision-making part of my brain. So that's in a nutshell how it affects the brain and what areas of the brain it affects. And this is for life, because it creates memory pathways that can't be reversed. You know, as you use the drug, every time you use it, these memory channels are carved into the brain. So you are vulnerable for relapse long after you've given up the actual chemical. You know, you can still relapse from it. So this is why we say this is a lifelong disease. It is not something that you can cure, but you can treat it.
So coming to treatment, you at one of the treatment centers in Lyndhurst, Adèl, what kind
are
of
we trying to do?
Yeah.
Well, as she explained the pathways to you, I think you must visualize highways in your brain. Okay. And when you start treatment, we're trying to put the lights off on those highways, but the structure remains. So, and that is why relapse almost forms part of treatment. We don't like it because you add chemicals to your brain again that puts the lights on the highway on. So relapse is not okay. But yeah, you have to start the process. It starts with detoxification, and unfortunately there's no medication that takes out the particles in the brain where, you know, it's not like Bart Simpson where you can maybe throw Enos in and it bubbles out. Some drugs takes much longer to leave the system. We get cannabis users that 2 months after their last use, they still test positive in the urinary tract. You know, if they take hair follicles, they can tell you what you've smoked 2 years ago, a month ago, so on. So it starts off with detoxification so that you get off it comfortably. We don't believe that you're fit. And then from there, the psychological part of the addiction needs to be addressed. And since not one thing causes addiction, not one thing is going to cure it. So it needs to be a holistic treatment that looks at various aspects of your life. Spiritual, social, physical. So a good program will represent all of that.
And you have all of this at your center?
We do have all of it, and then it goes beyond it as well, that, you know, you can't have your therapist in your life forever.
Yes,
so
absolutely.
you need to hand over to some form of aftercare. It's almost like cancer. You go into remission, and you need to go for checkups regularly, specifically because the psychological part of addiction is so strong. So then we hand over to fellowships like Alcoholics Anonymous and Narcotics Anonymous, because especially Alcoholics Anonymous has got braais, end of the year functions where people can go to and know that they're in a safe environment, they can socialize, and a professional person can't do it for you.
Yes.
You know?
Yes. And you get the help of the families in your centers?
We do a lot of family therapy. We sort of insist that they come on admission.
Okay.
You know, that's almost like the Betty Ford Clinic program. You need to have a significant other. It doesn't help that you get somebody in for treatment, it's expensive, and then you throw them out, you know. So there's a lot of NGOs that helps with displaced people, where they source the parents again and start with a reunification process before they come into treatment, so that whilst they're into treatment, then we address those issues in therapy. You know, why they ran away from home or were chased away from home.
So when you get somebody that is employed and then comes in for treatment, how do you deal with the employer? Do they allow a certain time off? And will they allow them back at work? Will they want some kind of report from you?
There's a lot of employers referring to us,
right.
You know, because if you, say for instance, drink at work and you're not in a life-threatening situation, like you're a train driver or something like that, they need to give this person a chance for treatment. So they refer to us, and we work with the HRs of quite a number of corporate companies where we would suggest the way forward. However, the process remains confidential. We can give pointers on what goes on. They usually take sick leave. It's regarded as a disease, and we've also got a halfway house to if people work and live in the area, to make their reintegration into the community slower. You know, that they would start working but come back to us in the evening, where they checked, where you know, the therapist would say, what was your triggers today? What was difficult today? So there's a follow-up. And your success rate on that is much higher.
Yeah, because I'm worried about the stigma for the person. Because now he goes back to work and other people will find out, now where was he? Because normally if you get admitted for an operation or a surgical procedure, you say, people actually come and visit you, other colleagues and things. Here now you have to maintain some level of confidentiality. So there's a lot of other issues that go around that for the person that is there. The concern now when he goes back or she goes back, what's going to happen at work?
Yeah, we do get a lot of employers that visit and colleagues. They're very supportive. It's a pandemic, you know, so for the grace of God, there am I. You can't say that addiction is never going to happen to you. So there's a lot of support, but it depends on the person being sent. You know, unfortunately, part of addiction is the secret. They lie about what they do, when they do it, how often they do it. So often the person doesn't want to divulge
the information.
Yes, so that makes it difficult, because then you're almost still in addiction mode. You need to let the secret out.
Yes, then you can get help.
Then you can get help.
We've had the same issue with our HIV patients in the beginning, in the early years. The stigma was so strong. Today, with all the education and awareness, patients say, no, it's fine, I've got a chronic disease, I'm on ARVs, and that's it, you know, and that way we can function and live. Otherwise, to do things in secret and try and get help is a even bigger challenge, because now you've got the problem, which is so difficult to treat, and now you've got this other compounding factors that work with it. So it is a huge challenge. But
and it causes anxiety.
Correct.
You know, because you've told this one I was there and that one I was there, and you don't need that.
And you don't need anxiety in a person who's got actually a dependency, which is...
And for us, the first step is to be honest. You have to be honest with yourself and the people around you, and to break that lies and the deceit that comes with it. It's that behavior change that's needed. And you also need to create support systems around yourself for your recovery. So that is important, that you do then disclose to people that you feel comfortable with yourself.
So it's really a very, very big problem, and I really admire the work you're doing. I mean, it's a big challenge. You're not only dealing with a medical condition that we've recognized, but the psychological, emotional, the social, people around it. So we touched on a specific context of poverty, but again, affluence brings its own problems.
Absolutely. We say that addiction doesn't discriminate.
Yes, of course. Yeah,
It
yeah.
affects everybody, affluent, poor people, people from different walks of life.
Yeah.
So it really
So the
is
affluence is just the ease of being
the
able to
ease.
buy and experiment.
the type of drugs they use is
And they use
slightly different.
different drugs.
Yes, more expensive drugs that they can afford, definitely. But you find similar problems.
Right.
And if you look at the process of addiction is exactly the same than any other person that goes through the process, yes. They might take a bit longer because they get away with it. They've got money to pay, so they don't get involved in criminal activities and get caught and in other kind of behaviors. But eventually it catch up with you, you know. You can't get away from that.
Right. So in terms of you going to schools and that, we spoke about this in the ad break, is unfortunately this International Day falls in our South African school holiday.
Yes.
So how are you guys working around that?
What we do is we also do the Kamoja campaign very successfully in Gauteng specifically. We roll out a whole formalized program, and that is what we do throughout the year. And during the school holidays, we have holiday programs that we would then run with kids that are now at home and there's no parents. So the holiday programs fill that gap to try and catch those children that are sitting at home with no parent or supervision. We've got camps. Some of our centers are running camps during this time with high-risk children, children that we are worried about. And then also the normal holiday programs where any children of that community can join us at a community center, and there's a formal program that we offer them with games and sports and fun activities to give them an alternative to using a substance. So that is the whole aim of these programs, is to say to kids, there's better things out there, than using a chemical. So we try and expose them to much as we can to different kind of activities they can do.
And then when the school term starts, there's a lot of schools that would invite us for specific reasons.
Okay.
You know, they would say the grade sevens, all of a sudden they've identified this problem, and then we individualize what we do depending on the school's needs.
Yes,
So all of this needs a lot of financial resources and human capital resources.
Yes.
So how well are you staffed in terms of it? Are you reaching out to most of the country, or depending heavily on volunteers?
We rely heavily on volunteerism. So we have, at the moment, we've got 350 professionals throughout the country. You know, if you think about that, it's a drop in the ocean. And we consist out of social workers, psychologists, our medical staff, our medical doctors that assist us. And then we have the majority, over 600 volunteers that assist us in implementing prevention and awareness campaigns in our communities, in our religious communities, in for instance, in schools, but also universities. We didn't even touch on universities or colleges as well, because there we also see other kind of issues coming forward.
And so it's a more loose arrangement in universities, so
definitely.
It's not so structured, so you can't get there.
Yes.
In terms of financial funding, is government supporting you?
Government is only paying 35% of our costs.
Your budget.
Our budgets. And so it's also not enough in terms of sustaining ourselves. So we can't rely on government funding only. We rely heavily on donations from the public as well as from corporates that assist us at times. But they also don't always understand what this is all about in terms of their corporate social investments. We also rely on medical aid schemes to pay for treatment.
Do they?
So they do. They pay for 21 days to 28 days, depending on
most
the scheme.
medical schemes.
They have to actually, by
is
law,
part
pay.
of their PMB?
Yes, so there is a benefit for people with a medical aid.
And it results under hospital treatment.
Hospital,
Okay, that's also, it needs to be promoted a bit more, because I'm not sure if all the doctors know that, and the health providers, because they're so busy worried about the other benefits. So this is something that you guys perhaps must let the medical associations know about it. And we'll continue in a short while after the ad break. Assalamu alaikum. Assalamu alaikum wa rahmatullah. Welcome back to the last segment of our show today for Health Matters. We're discussing drug and chemical dependence, issues around it. It's a international week for SANCA. They're running some special programs. Please visit their Facebook page. You have a website too?
Mm-hmm. Yes.
Yeah, okay, so SANCA, South African National Council for Alcohol and Drug Dependence. We have two very special guests in the form of Adrie and Adèl. We're really happy to have you here. We've got a few minutes left to wrap up. We just barely touched on a few things, but I'm sure the viewers have found the information that you imparted very, very informative and interesting. We've been talking about recreational drugs. There's a huge problem with prescription drugs, and maybe another program, but perhaps just touch on it and the challenges you face. I can tell you in our experience what we're having at our primary physician level, we're finding a real increase in the number of patients who have become addicted to prescription drugs, and also we're finding high-level people at CEO level and COO level coming to us requesting Concerta to make a presentation or for a big meeting. And I can tell you maybe 5, 6, 7, 8 years ago, I hardly used to get patients with that kind of request.
Yes, I think we call them the silent addictions.
Right.
So those are the addictions nobody ever talks about. Because it's also very socially acceptable.
Correct.
Nobody looks at your handbag, to see what stash you have in
there. That's right.
So
and you're getting it legally anyway.
And you're getting it legally. It's freely available. You now have efforts from the pharmacies for you to sign for codeine products and so on to try and control it a little bit better. But we find that over-the-counter and prescription medications are really problematic. And for the pure fact that some of these, especially the prescription medications, is highly addictive forming. So you find that there is a problem there. We also want to just stress that it mainly affects women.
Okay.
So we find that this is used by women, and I think that's a way of coping with all the pressure that's on women to deal with their daily chores, to deal with the challenges that they face as women. So we find that mainly women abuse, but most recently, which was quite concerning for me, is the abuse of codeine by the adolescents.
Yes.
So we're seeing that coming up quite strongly, and even in one of our communities, last week they reported that they're even using some of the children medication that contains codeine, and they will mix that, so we are really seeing a influx of codeine abuse, which is codeine is a synthetic form of your opioids.
So what we're finding, sorry to interrupt you, is at general practice level, we're finding school kids coming in and they're asthmatic, but they're not taking the asthma inhalers. They want the actual cough mixture which has codeine with it. So they actually say, no, my cough gets better with that one. And we know it doesn't, because asthma is a completely different condition. And that particular mixture doesn't work against asthma. So they're refusing to take the other thing, but they're requesting this. And what they're doing also, there's certain places like these parks where they're meeting. And they're actually taking these things which are available to them because they're getting it from the doctor or the pharmacist, and they're making some kind of cocktails. And codeine is a big component of that.
Definitely. So
the danger as well as the cocktails they make. They're not mindful what they put into it. No. But unfortunately, some pharmacies sell cough mixture in liter forms.
Yeah, look, your problem is a minefield. Not your problem, but our problem as general in terms of dealing with the kind of things we've been speaking about, and there's so much more going out there. But one of the issues that happens with prescription drugs is patients get admitted at hospital, and what's your experience there? They get coded into depression or anxiety, which is a recognized condition. Medical aid will pay for it. What do you people find patients getting that medicine in hospital, and after that, what happens?
You know what, your problem is that if they get admitted into, you get the dual diagnosis units, but they don't always get admitted in dual diagnosis units. So your doctor treats a symptom and not the origin of the problem.
Okay.
And by treating that, they add more chemicals. So more often than not, people would check out of hospital
With a bigger problem.
With a bigger problem, because the initial problem wasn't addressed.
And it goes back to stigma.
Yes.
People are so afraid that if they go for drug rehabilitation, that they would be seen then as an addict. So it's that labeling and the stigma
It's
goes
softer
back
on
to
the ear
that.
to be a depressant.
That you've been admitted for depression instead of for addiction.
And it's
problem.
like out of your control, and other
Yes.
things have triggered it.
Yes.
Which is a big topic which we can probably address on another day. Do you work with the psychiatrists? Are you guys working with the Psychiatry Association in trying to see how this can be dealt with? Are you guys in contact with them?
Yes, we do work with them. Not enough, I must be honest. I think more can be done to create an understanding for each other and the challenges that we face. And we're seeing a huge influx of comorbidity. So that is where we have to work more closely, because we can't just say this is now only a health issue. It's starting to become a mental health issue.
Yeah.
And that is where I think we need to work more closely
South
together.
Africa has also got the SAMS
Yes, the SAMS Association.
Which is?
It's a South African Association for
Medical Services.
Medical Services, and quite a lot of psychiatrists. Once a year, over a Friday, Saturday, Sunday, they meet and they come from all over, and they address issues. You know. And then everybody, various issues, addiction issues.
Okay.
Yeah.
It's mainly run by the University of Stellenbosch. So they would put that together, and you become a member of SAMS. So any medical doctor or psychiatrist can form part of them, and the treatment centers are also part of them.
You can even do courses online, CPD courses, doctors and psychiatrists through them.
Okay, that's very, very interesting. And in terms of your treatment centers, you're getting people with prescription drug dependency also coming to you, or not?
Yes, we do.
You do?
Yeah.
Okay.
We only admit men, 18 years and older, and even amongst them, you know, you will also get that your heroin addicts will get cross-addicted with codeine. If they don't have the money for the one, they'll go for the other. And then a lot of benzodiazepines as well, which is a very complicated withdrawal, you know, because they only withdraw like 7 days after the last use, and then it's serious. They would fit, and so that's why I would like them to be honest on, you know, what they've been using.
So what are you doing for the benzodiazepines? Which is a very, very big problem.
Yeah, it's a very slow detox process.
Right.
You know,
it has to be done inpatient?
Yes.
Yes, because there's always a possibility of it. We wean them slowly,
Right.
you know, and then we'll ask our psychiatrist, you know, to help us with medication, with withdrawal symptoms. That's not a habit forming, and that's not a benzo.
Do they normally replace with something else, or try and just wean off that and finish?
We first replace for harm reduction, and then we'll wean off that. Yeah.
So the benzos is the one thing. I just want you to quickly touch on the sleeping tablets, because people are on lots of sleeping tablets which are not benzodiazepines. You're having issues with that too?
Yes.
Definitely. Yeah, and especially, you know, I don't know why doctors think that if you go through a trauma, they must make you sleep. You know, so-and-so passed away, so, oh, you won't be sleeping tonight, and they'll
They
prescribe
already
a tablet.
start the problem before it has begun.
Yeah, and the problem with that is they crystallize the trauma. Because every time you wake up, you know, whatever happened is still there.
Yes.
So, yeah, no, it's a major problem.
Okay.
We've had guys that takes 90 sleeping tablets a day.
90?
90, which is like a 3-month prescription in one day, and they walk and talk to tell the story.
Really?
And how many doctors did they have?
You get sleeping tablets on the street as well. You can get anything on the street. It's not necessarily... It started with a doctor, but the supplements is from the streets.
Yeah, look, in South Africa we have lots of issues because obviously our control mechanisms and that are all not in place. And like you said from the beginning, your challenge is you can't stop the supply, so you're looking to look at it from the other end.
That's right.
We've reached the end of the program. It's gone so quickly, but take-home message from each of you for our viewers, and hopefully we'll invite you again.
Thank you. Thank you for this great opportunity. I just want to say to the viewers out there, it's never too late to change your life.
Okay.
And that we are all affected by this in one way or another, and there's help available. You can contact us. You've got our contact numbers. You can go online. You can go onto our website for our different centers.
Thank you very much. Yeah?
Yeah, yes, thank you for the opportunity. My message would be that never say never. And nobody gets up one day and decides, you know what, I want to be a drug addict because I don't want a family and a job and a this and a that. And if you're in that, there's no stigma to it, please reach out for help.
Thank you very much for coming. Jazakallah khair to all the viewers for watching the program today. It's an exceptionally interesting topic, but more than that, it is very important for all of us to take responsibility for what is going on in the community and to try and provide our assistance as best as possible, not to judge anyone, but try and help whoever we can, and knowing that there's some excellent support structures out there like SANCA. And inshallah, until next week, see you again. Assalamu alaikum wa rahmatullahi wa barakatuh.